Hi everyone, my name is Jason and I'm a medical student from the University of British Columbia from the graduating class of 2023. I'm here today to give a presentation on the approach and management to gynecomastia. This video was made from the help and direction of Dr. Jillian Roller, a plastic surgeon who also trained at the University of British Columbia, and without further ado, let's get started. The learning objectives today are to review gynecomastia definitions, demographics, pathophysiology, classification, and then talk about management options. Let's begin with the basic definition, which for gynecomastia is the benign growth of glandular breast tissue. Gynecomastia is different from pseudogynecomastia, which is enlargement of the chest due to adipose tissue rather than the glandular tissue. The key difference between these two conditions is the type of underlying tissue that's responsible for the clinical presentation. For the purposes of today's talk, I will focus on true gynecomastia with glandular tissue-based pathology. In terms of demographics for gynecomastia, it's important to know that gynecomastia is very common and is the most common breast problem in males. Up to 65% of adolescent boys can be affected with this condition, with 75% of the cases being bilateral. Gynecomastia can occur for several reasons. In general, the pathophysiology is related to an imbalance in circulating sex hormones. There can either be an excess in estrogen, decrease in androgens, or enhanced sensitivity to the normal amount of estrogen that is circulating. Various examples of these potential imbalances are shown in the diagram on the right. Gynecomastia can be classified clinically or histologically. In the majority of cases, the etiology of gynecomastia cannot be ascribed clearly to a cause and is deemed idiopathic. Clinically, cases can also be classified into physiologic, pathologic, and pharmacologic cases, and we will discuss these in detail over the next few slides. In contrast, histological classifications are based on tissue architecture that is seen under the microscope. They can be considered florid, fibrous, or both. And generally, though, clinical classifications are used as it will help guide treatment options, and we will focus on the clinical classifications in today's talk. The first clinical distinction for gynecomastia that we want to talk about today is physiologic gynecomastia. Gynecomastia typically peaks at 3 ages, during the neonatal period, during puberty and adolescence, and then later in adult life in the elderly. And the background physiological causes for these particular peaks are commonly due to excess in circulating estrogens. In neonates, gynecomastia occurs in up to 60% of the population and is secondary to circulating maternal estrogens and always resolves by around 1 year of age. In puberty, up to 65% of males can experience gynecomastia. However, 3/4 of that population resolve the gynecomastia spontaneously within about 1 to 2 years. It is thought that this is due to lagging testosterone production and increased tissue sensitivity while going through this particular growth period. In the elderly, up to 60% of males in their 70s can have gynecomastia. Now, if this is due to increased conversion of testosterone to estrogen in the peripheral fat, they do not tend to spontaneously resolve. The second category we want to talk about today is pathologic gynecomastia, which can be due to an array of conditions. Overall, the pathological causes are still the result of an imbalance in the estrogen to testosterone ratio in the body. Causes secondary to increased estrogen include adrenocortical tumors, or secondary to higher aromatization as seen with aging, obesity, liver disease, or testicular or adrenal tumors. Other causes include exogenous sources, decreased testosterone production secondary to trauma, radiation exposure, medication use, as well as HIV or other chronic illnesses. The last category that we want to talk about today is pharmacologic gynecomastia. There are some very common drugs that are associated with gynecomastia that you can see on the right-hand side of the screen right now. These drugs include anabolic steroids, antiandrogens including spironolactone, finasteride, dutasteride, some antibiotics and cardiovascular medications, antipsychotics and antidepressants, and also it is important to screen your patients for drugs of abuse such as marijuana, alcohol, amphetamines, heroin, and methadone use. As an aside, I wanted to quickly touch on the risk of malignant transformation, as a common worry from patients is that having this breast tissue proliferation may transform into a malignancy somewhere down the line. The good news is that there is no demonstrable increased risk of breast cancer in males presenting with gynecomastia. The sole exception to this is in Klinefelter syndrome, where males are born with an extra X chromosomes, and this syndrome results in a 60-time increase in breast cancer risk. It's also associated with an array of other health conditions such as type 2 diabetes, coagulopathies, osteoporosis, developmental delay, and infertility. The diagram on the right-hand side of the screen helps to highlight some of these physical features of a patient with Klinefelter syndrome. While we are focusing on gynecomastia for today's talk, it's still important to consider and rule out other possible differential diagnoses throughout the evaluation process. As previously mentioned, pseudogynecomastia may present very similarly but has different pathophysiology and treatment considerations. Other important diagnoses to keep in mind include male breast cancer, which, while rare, is a very serious condition to not miss. Common benign lesions are also possible, such as cysts, lipomas, hamartomas, etc. Infiltrative disorders such as sarcoid can also sometimes masquerade as gynecomastia. Specifically, male breast cancer, while rare, should be considered in patients with risk factors such as positive family history, genetic risks such as BRCA mutations, Klinefelter syndrome, cryptocortisone, past radiation exposure, or exogenous estrogen sources. For the next portion of our talk, I wanted to focus on the clinical evaluation of a patient suspected to have gynecomastia. Firstly, the history. It is important to ask about onset, duration, pain, weight fluctuations, as well as diet and lifestyle. A focused history that involves the breasts should be done, focusing on any changes over time, previous exposure to radiation, previous procedures in the area, and also be sure to evaluate for the psychological impacts and expectations of the patient. Also ensure to review the patient's medication history and screen for medication and supplements that are associated with gynecomastia. It is a good time at this point to review their smoking, marijuana, steroid, and alcohol use habits as well. After a thorough history, a systematic physical exam should be performed. This encompasses assessing body habitus using parameters such as height, weight, and BMI, as well as a breast exam and a testicular exam. For the breast exam, note if one or both breasts are affected, the degree of deformity in terms of excess skin, excess parenchyma versus adipose tissue. On inspection, it's important to look for skin striae, any indurations, tethering, or peau d'orange. On palpation, evaluation for the quality of the chest tissue, any present masses, and the pain should be done. Be sure to perform a testicular exam in all patients to assess for potential testicular tumors that may be a source of the hormonal aberration. Any suspected gonadal pathology should be worked up with an ultrasound and appropriate blood work. In terms of labs, while many elements of gynecomastia are clinically based, there are some supporting investigations that can be useful. In terms of blood work, endocrinology workup can be helpful to assess the hormonal axes surrounding estrogen production. This would include LH, FSH, estradiol, testosterone, as well as assessment of baseline organ function such as liver function tests, thyroid hormone, and creatinine/blood urea nitrogen. Imaging such as ultrasound can be used for masses found on breast exam and abnormal testicular exams, and special tests such as karyotyping are available. Biopsies can be done if the diagnosis is uncertain or if tissue samples is needed, such as in Klinefelter syndrome. Having said all that, in general, it is important to remember that most healthy adults with gynecomastia do not need extensive workup, especially if the history is non-concerning and the physical exam is benign. After the physical exam is performed, the patient can now be staged, which can help in turn dictate management decision-making. The Simon classification is the most common way to stage gynecomastia. Grade 1 of the Simon classification is where there is a small visible breast enlargement with no skin redundancy. Grade 2A and Grade 2B is where there is a moderate breast enlargement with either no excess skin or with excess skin, as shown in the diagram on the left. In Grade 3 of the Simon classification, there is marked breast enlargement with skin redundancy, and it is at this stage this typically resembles a pendulous female breast. Moving on to the management options for gynecomastia, as gynecomastia has varied etiology, the management options should address the suspected etiology for each patient. This can include a spectrum of non-surgical and surgical interventions. Initial management of gynecomastia should include non-operative strategies, which can include the following. Number 1, identify and reversal of the known or suspected etiology. This can include stopping drugs, alcohol, marijuana, changing any offending medication, or treating any identifiable underlying disorders. Number 2 is observation and watchful waiting. As previously described, all neonatal presentations will resolve, and the majority of adolescent presentations will resolve over 2 years' time. Number 3 is dietary and lifestyle changes. Patients should minimize soy-based products and be encouraged to optimize healthy lifestyle changes such as exercise. Number 4 is medication-based therapy. For example, in patients with deficiencies in testosterone, this should be supplemented. Indications for the surgical management of gynecomastia include failed non-operative interventions or confirmed pathologic gynecomastia. Patients with a predisposition for breast cancer, such as BRCA mutations, Klinefelter syndrome, and patients with a non-physiologic cause of gynecomastia, which is not resolved over a 12-month period, are also candidates for surgical intervention. Picture on the right-hand side of the screen here shows an example of gynecomastia surgery, showing the removal of a large glandular mass of male breast tissue through an infraareolar incision. There are multiple surgical options to treat gynecomastia, which include liposuction, direct excision of parenchyma, skin resection, and possible free nipple grafting. Going down the list on the left-hand side, liposuction can be used as a primary treatment for grade 1 gynecomastia or as an adjunct procedure for higher grades. It's important to note that it should not be used in cases of potential malignancy. Direct excision of skin and breast parenchyma can be performed with different excisional techniques such as en bloc versus pull-through, and in higher grade gynecomastia, significant skin and parenchyma excision is required and free nipple grafting may be considered. The patient's presentation, Simon classification, and goals will help the surgeon determine which surgical options are the best. The next 2 slides will go through some case examples for various patients with surgical management of their gynecomastia. For milder forms of gynecomastia, including Simon classification 1 and 2A, where there is no skin redundancy, these patients can be treated with either liposuction alone, as seen on the images on the left-hand side, or with direction excision of the excess breast parenchyma through a periolar incision, as seen on the images on the right. Additionally, liposuction can be employed in addition to direct excision if needed. In the management of more severe gynecomastia, a combination of techniques can be used, which include options for skin-sparing mastectomy, mastectomy with skin resection, and/or mastectomy with free nipple grafts. These techniques will be chosen based on factors such as patient goals, surgeon preference, as well as other anatomical considerations that may be clinically present. Moving on to complications of surgical treatment, the most common early complication after surgery is hematoma formation. The most common long-term complication is undercorrection, which adversely affects cosmetic satisfaction for the patient. Seldomly, overcorrection of central tissue may lead to a saucer deformity, and rarely there are excess skin that requires re-excision. In conclusion, I want to go over some of the key points that were touched on in today's talk. Gynecomastia is common, especially in adolescent populations. In most cases, gynecomastia is idiopathic. It does not confer increased cancer risk, aside from those with Klinefelter syndrome. A thorough medication history and testicular exam is clinically critical. A thorough history and physical exam is crucial for optimal management, and there is an array of surgical options that are available. These are the references to the talk. Thank you so much for your time and listening to me going through the approach to gynecomastia today. And again, a huge thank you to Dr. Janine Roller for making this presentation possible.